Good afternoon, everybody. Today, we're going to talk about cortisol, which is really an important biomarker that in the traditional world really doesn't get enough attention. And here is our disclaimer. And we're going to do a quick review from the past two webinars where we're just going to talk about the facts. We're going to debunk the myth about pregnenolone steal. We're going to talk about cortisol, DHEA, and the stress response, and why we should measure cortisol metabolites, and the cortisol awakening response. And then we're going to briefly talk about assessing HPA axis function and dysfunction. So from the past two webinars, what tests do we do in females? I'm not going to go through all of these. I'm just going to point out for you that, again, the reason to measure prolactin is you're not looking for a prolactinoma because you would have really in females, they would have a milky breast discharge. You're really looking to see if signaling is interrupted like we talked about last week, because elevated prolactin can inhibit kispeptin, which is important for the release of gonadotropin-releasing hormone, and FSH and LH. I do FSH and LH at baseline because they tend to bounce around. And here are just the facts. Determine the reproductive stage using the modified Straw criteria. Peri and postmenopausal females less than 6 years from menopause probably do best with trough serum LC-MS levels at approximately 45 picograms per mil. So what is an LC-MS level? On a Quest laboratory, that's the ultra-sensitive estradiol, and in LabCorp, that's an LC-MS or mass spec value. Postmenopausal females greater than 6 years but less than 10 years probably do best with trough serum LC-MS levels around 30 to 40, or Dutch levels at greater than 0.7 to 1.8 nanograms per milligram. And postmenopausal females greater than 10 years or greater than age 60 do best around 30 picograms per mil in serum and 0.7 to 1.3 to 1.5 in Dutch. And when we're talking about compounded E2 and E3 creams and gels, I personally do not recommend using vaginal estradiol for hormone replacement therapy, because then, especially in women with a uterus, you need to be concerned about progesterone. And in that setting, you should use vaginal progesterone. A lot of people do this. It makes me too nervous. Why does it make me nervous? Endometrial cancer risk. In peri and postmenopausal females less than 6 years and up to 10 years, start with a 50-50 mix, a half a milligram each, and it's written as bias 50-50, 2 milligrams per mil. Using a topic click, you apply 2 clicks. Peri and postmenopausal females greater than 10 years from menopause start with the same thing, but only 0.25 milligrams, and again, 2 milligram per mil using a toppy clip, apply 1 clip. If you're going to do an 80-20, E3, E2, it's 2 milligrams per mil, apply 2 clicks. With a patch, start at 0.25 milligrams per day. And this is predominantly in younger, recently menopausal women. In older menopausal women, I typically start off with a cream because it's easier to monitor, especially following the serum and Dutch guidelines that I put forth. When we're talking about pellets in females with a uterus, never do it. It's too risky. In females without a uterus, start with creams, gels, patches, and transition to pellets once you understand how they metabolize hormones and have some pellet experience. Pellet doses in females without a uterus is typically 6 milligrams. Vaginal E3, a half a milligram at night times 2 weeks, then 2 times a week for 2 weeks, and then PRN. Progesterone, oral micronized progesterone, 200 milligrams at HS, especially in women with a uterus. If you want to use vaginal micronized progesterone, 100 milligrams at HS. And please don't use transdermal topical progesterone to protect the endometrium. It just doesn't work. Now, when we're talking about testosterone, all deliveries of testosterone improve symptoms and clinical outcomes. And remember that females synthesize somewhere between 0.2 and 2.25 milligrams a day. So you're shooting for luteal ranges with about a mean of 58 nanograms per deciliter. Now, this is going to be above the upper limits of, say, the typical Quest LCM-SMS range, which goes from 2 to 45 nanograms. But you're looking for mid-luteal ranges. And your ranges will be a little higher if you put in pellets, which we'll get to in a second. Dosing should be a 1/10 to a 15th of male dose, and the typical male starting gel dose is 50 milligrams a day, so somewhere between 3.5 and 5 to maintain physiologic levels. And there are the studies that looked at different doses. Here's the typical starting doses for a topical cream is about 1 milligram a day. For vaginal application, it's 0.5 milligram, because remember, the vaginal application is a mucosa, where topical application, the skin is a barrier. Typical starting doses for injections are 5 milligrams per week, and pellets for every 75 nanograms, you want to increase testosterone, you want to give 75 milligrams. And remember, you need to consider weight, activity, the HPA axis, the gut, and if you get site reactions, it's often related to HPA axis dysfunction, which we're going to get to. And there's wide dosing ranges for pellets in the literature. Typically, consider 1 to 1.5 milligrams per kilogram. I'm a very conservative pelleter. Less than 100 milligrams, I typically do 50 milligrams. 100 to 120, I typically do 75 milligrams. 120 to 145. I still, if I'm going to use a pellet, use 75, but I usually start with another delivery system until they lose weight. And as we get into the Dutch test, you'll understand that with obesity or individuals who are overweight, they tend to be inflamed. Obesity upregulates 5-alpha reductase, so testosterone is going to go to estradiol, and inflammation upregulates 5-alpha reductase. Obesity upregulates the aromatase enzyme, which basically increases the conversion of testosterone to estradiol, whereas inflammation will increase 5-alpha reductase, which increases the conversion of testosterone to DHT, which is when you get all of the side effects from pellets. It's not the pellet. And when we're talking about monitoring, if trough levels are greater than 60 nanograms per deciliter or less than 35, consider adjusting the dose and frequency. And this comes from the male literature, as you'll see in a second, because female doses should be about 1/10 of males. In males, you'll see if trough levels are greater than 600 or less than 350, you'll consider adjusting the doses. Now, what about our male counterparts? Well, again, all of these things we've already talked about. Again, prolactin, mainly to look at signaling of gonadotropin releasing hormone, FSH and LH. And why do I check FSH and LH more than at baseline? David and I talked about this previously. Well, if you're giving a gentleman gonadorelin, you want to make sure their LH and FSH come up if they're on the low side. If you're giving a gentleman Clomid, you want to make sure that you're getting a response. And then if you're giving somebody testosterone therapy and they say they're not feeling it, or they just don't, get the effects they expect, look and see if they're hitting the receptors and decreasing FSH and LH. If they're not, and their quote unquote serum levels look okay, this is where you look to do androgen receptor sensitivity testing. This is where you may look to do an ultrasound. All right. And again, regardless of delivery, a serum trough level greater than 500 improves sexual function, body composition, bone mineral density, and cardiovascular outcomes. Serum total, again, LCM, SMS, estradiol levels should be maintained between 20 to 40, the goal 30 to 35 for optimum benefit. And remember, young males on Clomid, Gonadorelin, or Kisspeptin, for Clomid, you're going to start with 25 milligrams every other day or every day, depending on their hormone levels, and anastrozole need is dependent on baseline and treatment estradiol levels. For young males with pre-treatment high-end LHs who may not respond to gonadotropin, Kisspeptin, or Clomid, they may need testosterone and gonadorelin to maintain testicular size and spermatogenesis. And here are typical starting doses, which is adapted from the 2018 guidelines. And don't forget that testosterone therapy, and DHT do not cause prostate cancer, but elevated DHT levels may increase prostate size and BPH. And here are the guidelines for getting a urology consult. Let me point out to you that even though the guidelines say a PSA of greater than 4 nanograms per mil at any time, many experts now suggest a PSA of greater than 3, and that's what I've changed my practice to. Now let's get into cortisol. There are some people who believe that cortisol, like other hormones, comes from circulating hormones, i.e. pregnenolone in this case. Whereas, and we know that all estrogens come from androgens, cortisol is not like that. It doesn't come from serum pregnenolone. But when you look at the steroid pathway, it's easy to see how pregnenolone, serum pregnenolone goes to progesterone, and then you get cortisol. But this is not how it happens. But the most important point on this slide is a cell's enzymatic machinery will determine what hormones it actually produces. In other words, the zona fasciculata does not produce sex hormones. The Leydig cells and the granulosa cells and theca cells do not produce cortisol. All right. Now, how is cortisol made? The brain gets a signal, ACTH is released, ACTH circulates and finds its way to the adrenal cortex cell. Once it gets to the adrenal cortex cell, it stimulates the star protein, which shuttles cholesterol, de novo LDL cholesterol. Now we're in the adrenal cortex cell, we're not in the circulation, into the mitochondria. And it's in the mitochondria where cholesterol is synthesized to pregnenolone, metabolized to pregnenolone. Pregnenolone then leaves the mitochondria, enters the endoplasmic reticulum, where progesterone and actually 11-deoxycortisol are made. 11-deoxycortisol finds its way back into the mitochondria, and it's in the mitochondria where cortisol is produced. Cortisol leaves the mitochondria, leaves the adrenal cortex cell, circulates, and does its thing. So you can give people pregnenolone and it's not going to go to cortisol. Just understand that. You can give people progesterone and it's not going to go to cortisol. All right, now let's talk about cortisol and the stress response. When we look at the traditional endocrinology model of our traditional peers, there's this disease, and then everything else in between is considered normal. So there's a distinct delineation between disease states and normal. In the functional and integrative world, we look at more than just normal and disease. We look at the effects of stress and the stress response. And that's really what we're going to be talking about today. Some terms you need to be familiar with if you read the literature are allostasis, which is the ability to adapt to a changing environment, Allostatic load is the accumulated wear and tear resulting from daily life. Then there's resiliency, the ability to quickly bounce back from a stressful situation. It's your ability to cope. And then there's allostatic overload, when the demands exceed your coping resources for a short period of time. And then there's toxic stress, when this allostatic overload continues, it's strong, it's frequent, it's prolonged, and you don't have adequate reserves to meet any of those demands. And when we think about the adrenal gland and the hormones it produces, we're going to go back to the basics. The adrenal cortex has three zones: the zona fasciculata, which makes cortisol; the zona reticularis, which makes DHEA and DHEAS; the zona glomerulosa, which makes aldosterone; and then the adrenal medulla, which produces epinephrine and norepinephrine. And really, the acute stress response is a two-phased response. There's the rapid response, which comes from the locus coeruleus, from the brainstem and the spinal cord, which causes the release of norepinephrine, which triggers the hippocampal release of corticotropin-releasing hormone, which then releases ACTH and then releases cortisol. So cortisol is the slower response. The body makes cortisol when it's needed, as opposed to catecholamines, which are stored and is ready for a threat. And the lag time is about 10 minutes. But what I want to point out to you, that not only does cortisol inhibit hormone activity, it also increases catecholamine release, which triggers the release of pro-inflammatory cytokines. And so this is why stress is associated with an inflammatory state. And this just explains what we just talked about. Now, when you're running away from a white tiger, and we're talking about fight or flight, the goal is to provide you with energy to maintain that fight or flight. So you want to maintain glucose levels, you want to increase focus, you want to increase heart rate and blood pressure, blood muscle flow increases. But parasympathetic stuff, like the digestive efforts, are decreased. You get decreased sex hormone response. When you're running away from a white tiger, nobody's interested in procreating, and then you have a diminished immune response. And when these things become chronic, what is the maladaptive body's response? Well, you get insulin dysregulation, you get dysglycemia, you can get insulin resistance and diabetes, central adiposity, immune dysregulation, chronic fatigue. You have decreased sympathetic nervous system activity. You can get hypertension, hyperlipidemia, endothelial dysfunction based on sympathetic outpouring. And then you can get sex hormone imbalances. In females, it can lead to infertility, irregular and heavy cycles, decreased libido. In males, you get infertility, low testosterone, decreased libido, and erectile dysfunction. And just understand that cortisol and testosterone have an inverse relationship. Testosterone is going to decrease as the HPA axis gets upregulated. Now, we need to distinguish this from disease, right? HPA axis dysfunction and the stress response are not disease. Cushing's disease is typically secondary to a pituitary tumor. Addison's disease is an autoimmune response. And what happens is you don't get that normal diurnal curve. You'll have somewhat of a diurnal curve or no diurnal curve, and it'll be high for Cushing's and it'll be low for Addison's disease. And so as we dig deeper into the HPA axis, it's really important to understand free cortisol and free cortisone. Free cortisone is free cortisol. It is the inactive components, and the two are always interchanging in the circulation. Cortisol is typically bound to corticosteroid binding globulin, and only about 10% of it, or up to 10% of it, is free. Free cortisol and free cortisone both follow a diurnal pattern, which we'll talk about here in a minute, meaning that as the sun goes up, cortisol rises, as the sun sets, cortisol decreases. And most of free cortisol's release should have come in the morning. So if there are spikes at other times during the day, that indicates an abnormal stress response. Now, let me orient you. This is saliva, this is cortisol, this is cortisone. This is the patient's response, which we'll talk about. This is the upper limits of the reference range. This is the lower limits of the reference range. And you want a nice cortisol curve to be right smack in the middle. And as you see, it increases in the morning and then continuously lowers till bedtime. And here you see cortisone and cortisol are interchangeable. All right, now where does DHEA come into the stress response? Well, first of all, it's synthesized not only in the adrenal cortex, but the gonads and the brain. DHEA is an androgen that is a parent hormone of most of the steroid hormones. And in fact, it is, as we know, all estrogens are synthesized from androgens. But importantly, DHEA is involved in the stress response. And the literature tells us that it's an acute stress marker. It tends to increase and peak within 1 hour of an acute stress response. DHEAS, which doesn't cross the blood-brain barrier, is in serum as DHEAS. Why is that? A sulfur group is added to stabilize DHEA in blood so that it can reach target tissues. DHEAS, as opposed to DHEA, does not follow a diurnal pattern. It tends to be constant. So it's really a better measure of adrenal reserve. And when we replace DHEA, start low, go slow. I typically start off with drops in females, 2.5 milligrams, in males, depending on where they are, what their DHEAS levels are, somewhere between 5 and 10 milligrams. Too much DHEA, females can get acne, facial hair, weight gain. It's an androgen. Males, increased aggression, hostility, and irritability. And for those of us who like pictures, I'm sorry, this is a bit fuzzy, you can see all of the systemic effects DHEA has. And in fact, you get increased sebum production and increased acne and oily skin if you give somebody too much. But it's got a lot of other important effects. It's an anti-inflammatory, and in fact, in lupus, they tend to give this in much higher doses. And so here are some key points. Cortisol is the universal stress marker. There is no such thing as pregnenolone steal. Cortisol is synthesized from de novo LDL cholesterol in the adrenal cortex cell. Acute cortisol effects are different than chronic cortisol effects. DHEA has numerous systemic effects. DHEA is released in response to acute stress, and DHEAS does not have a diurnal pattern, is a better marker of adrenal reserve. Now, some people, because of the quote-unquote increased acne, the androgenic effects, give keto DHEA. There's no literature that supports the use of keto DHEA having the same effects as DHEA does. And so now we're going to move on to why do we test cortisol? Well, cortisol drives inflammation. And inflammation is the root cause of most, if not all, inflammatory diseases. And so because it's important that we understand that we're doing evidence-based medicine, are there studies that link saliva and urine testing to clinical outcomes? And I'm going to do something that's near and dear to my heart. There are many other studies out there. I'm going to talk about cardiovascular disease, which still is the #1 killer in men and women. The Inner Heart study was the largest study to assess long-term stress. Over 15,000 MI patients, 14,820 controls. Stress was documented by questionnaire, and they set out to determine the strength of the association between risk factors, traditional risk factors, and acute MI. And what they found was that the odds ratio of having an infarct was more than doubled in individuals with chronic stress in addition to conventional risk factors when compared to stress-free individuals. So they concluded that psychosocial stressors are significantly related to acute MI risk in all populations. And here, if you like graphics, when you add risk factors, you see the odds ratio of an infarct goes up, and then when you add psychosocial stressors, it more than doubles. This was the cardiac study. It was a coronary artery calcium study, and it linked cortisol patterns to coronary artery disease. And what they did, they set out to determine if coronary artery calcium was associated with the average daily cortisol levels and the slope. 718 young individuals, so you wouldn't expect them to have a lot of coronary artery calcium. Their average age was about 40, but they were followed for 15 years. And what they found was a flat diurnal cortisol was associated with coronary artery calcium. And when compared to the group with the steepest slope, the group with the flattest slope were 3 1/3 more likely to have coronary artery calcium. So they concluded that HPA axis dysfunction may affect coronary artery disease risk, but that's a surrogate marker. Now, when we get to a mortality study, this study set out to examine the association between cortisol patterns, cardiovascular and non-cardiovascular mortality, a large study. Over 4,000 men and women, the mean age was 61, and they were followed for 6.1 years. And what they found was that a flattened cortisol curve was statistically significantly associated with increased cardiovascular mortality. And elevated PM cortisol was an independent predictor of subsequent cardiovascular mortality. So they concluded a flattened cortisol curve and elevated PM cortisol levels are robust cardiovascular mortality predictors in middle-aged adults. And now let's look at urine. This was the first urine study done. Their objective was to determine whether 24-hour urinary-free cortisol levels predicted all-cause and cardiovascular mortality. Urinary-free cortisol was divided into 3 terciles: low, moderate, and high. And what did they find? Guess what? Urinary-free cortisol strongly predicts cardiovascular mortality. And when they looked at the groups, what they found was that in those individuals with no baseline cardiovascular disease, they had a 6 times increased risk of dying from a cardiovascular event. In individuals who had baseline cardiovascular disease, their risk was 9.2 times increased from dying of a cardiovascular event. So they concluded that urinary-free cortisol is a strong cardiovascular mortality predictor in persons with and without baseline cardiovascular disease. Well, that's all great. Now, what do we do with this information? Well, let's start with saliva, because saliva is the gold standard. And just so you know, Dutch validated their dry urine test against the gold standard of saliva, and it is a reasonable surrogate. And as you'll see in a few minutes, urine, you can't do a cortisol awakening response, whereas saliva does. So if we look here, this is a high, but it's a flattened response with a really elevated nighttime cortisol. So this individual has an increased risk of dying from a cardiovascular event, as well as increased coronary artery calcium, a surrogate marker. This individual, again, has a flattened cortisol curve, much easier to see, and an elevated nighttime cortisol. Same thing, increased coronary artery calcium risk and cardiovascular mortality. Now we get to urine. This is flattened. This is somewhat flattened. I mean, even if this is high, this should come down. And again, increased coronary artery calcium and increased cardiovascular mortality. And so there are our key points. Cortisol drives inflammation. Chronic stress is significantly associated with MI risk, amongst other. And cortisol is a strong predictor of cardiovascular risk events and mortality. So how do we measure this risk? Well, we can do saliva and the cortisol awakening response, or we could do urine and metabolites, or we could do a combination of both called the Dutch plus. Now, how do you decide what test to choose? Well, the test you choose really depends on the question you're asking. Both will give you the diurnal curve, but if you want to know about HPA axis resiliency, you're going to do saliva because you can only get a cortisol awakening response in saliva. If you are interested in total cortisol production and cortisol use, you're going to use urine. And so let's talk about the cortisol awakening response. What is it? It is a mini stress test. It's a marker of HPA axis resiliency, and when it's abnormal, it signals neuroendocrine maladaptation. So how does it happen? When you sense awakening, it's not when you're awake, when you sense awakening, that's the first point. Eyes open, light hits the back of the retina, and light stimulates hippocampal suprachiasmatic nucleus to stimulate the hippocampal PVN paraventricular nucleus, as well as the suprachiasmatic nucleus also directly signals the adrenal cortex. You get a sharp rise in the cortisol spike as you go from conscious, which is this point, to alert. That's that point. And really, timing is key when you're talking about the cortisol awakening response. So you want to tell the patients when you kind of sense awakening is when you do this first point. And 30 minutes later, when you're awake, is when you do this second point. And this is correct when you look at the entire curve. If it's delayed, if you wait till you're really awake, then you're going to get an increased cortisol awakening response because it's further along on this bell curve. If you wait even longer, your 30 minutes is going to be here and you're going to get a decreased cortisol awakening response. And if you wait even longer, you're going to get a negative cortisol awakening response. So let's look at an example here. And I showed this before. Here is a negative cortisol awakening response. This automatically should tell you that the patient did not do the test correctly. This is the second point. This should be the second point. They waited too long to do the first point, and their second point is negative. But overall, you can see that this is a low cortisol curve. This is a low also cortisone curve. It's a little better than this one, and we're going to talk about that in a little bit. And so where will the cortisol awakening response really be helpful? You get a urine-free cortisol. Now, neither one of these individuals have Addison's disease, but they're both low. And you want to know how aggressive you need to be with their treatment. So you do saliva at the same time, and you see that this individual has much more resilience because they have an adequate cortisol awakening response. It may be on the low side or it may be normal. I'd have to calculate it. But here you see this is flat. Now, 25% of the population will be non-responders. But when you see a cortisol awakening response, a cortisol curve that looks like this and a cortisol awakening response that looks like this, it's unlikely to be a non-responder. This is the extreme on the other side. This is somebody who is close to burnout, if not have a clinical burnout already. And so why do we measure cortisol metabolites? Well, free cortisol is the best way to assess the HPA axis, right? Cortisol metabolites are the best way to assess utilization and production. Now, this looks complicated, but it's not. Let's start here, up at the top. 11 beta HSD1 in vitro is bidirectional, meaning it could activate cortisol or it can inactivate cortisol. But in humans, it predominantly acts to activate cortisol. And this happens in the liver, adipose tissue, gonads, brain, and vascular smooth muscle. But here, mainly. 11 beta HSD2 inactivates cortisol, and it is primarily located in tissues that have an abundance of mineralocorticoid receptors, because you don't want cortisol activating or sitting on the mineralocorticoid receptor. You want aldosterone to do that. It's primarily in the kidneys, the colon, and the salivary glands. Now, this is the liver where ultimate cortisol metabolism occurs. So whether you have active or inactive cortisol or cortisone, then goes on to be metabolized by 5-alpha and beta reductase. Now, remember that 5-alpha reductase is really about peripheral metabolism. You have some 5-alpha reductase in the liver, but it's mainly what happens peripherally, whereas 5-beta metabolism predominantly happens in the liver. And so how do you know what to do when you have these things? Well, Dutch's metabolized cortisol dial really represents the total free cortisol and free cortisone produced by the liver on the day of testing, because the liver is the primary site of metabolism. When you have more THF, this suggests that the body had a high need for active cortisol that day, and circulating free cortisol was predominant. This is seen here in high stress states, inflammation, or with habitual licorice use, or in somebody that you gave licorice use because they had low cortisol, because licorice inhibits the inactivation of cortisol, and you may have overshot and now their cortisol is higher. More THE, or it's needed. It's what is needed for that day. More THE suggests that free cortisol was circulating as inactive hormone that day, not being readily used by the tissues before finally being processed. And this is a lot of times seen with chronic stress, and where you have high free cortisol and it's trying to nudge it towards cortisone to protect the mineralocorticoid receptor. And so here is an example, and don't really worry about the details of this. We'll be getting into cortisol patterns over and over repetitively in the next number of webinars. But what I want you to see is this cortisol is high. This cortisol is even higher, so we're pushing cortisol to cortisone to try and inactivate it, so you see more cortisone metabolites. You see a lot of cortisol being produced, but the body says, hey, we need to protect the mineralocorticoid receptor, so we need to shunt this towards cortisone. Or the body's saying, wait, I don't need this much cortisol. I'm not running away from a white tiger anymore. And aside from testing, or before we even get to testing, how do we in the office determine where somebody is along this HPA axis continuum? Well, it is a continuum. You have your fight or flight response with high cortisol, high free cortisol, high metabolized cortisol, and then you have the other side of it, which is burnout or exhaustion, where you have low cortisol and everything is low. And the truth is, most people are somewhere in the middle. And that's the beauty of this test, because it will help you figure out where somebody is along the HPA axis continuum. There are also clinical criteria. This is a very nice article. These are validated clinical criteria. And here's a validated questionnaire. Is the patient clinically stressed? Any from A1, plus you must have A2, and 2 out of the 3 B criteria, either B1 and B2, B1 and B3, B2 and B3. Then you know that somebody is clinically stressed. I give individuals this questionnaire in the office. And there are also signs and symptoms. Now, these are generalizations. high cortisol signs and symptoms, low cortisol signs and symptoms. And then you have syndromes and disease states, high cortisol, low cortisol. And again, these are generalizations because you remember, not every patient reads the textbook. And then here are our key points. Dutch urine is a reasonable alternative to Dutch saliva, and the question being asked will determine the test. And history and validated questionnaires will help assess where along the continuum a patient is. Now, I bring up thyroid and the stress response because I've seen many people be overtreated with thyroid hormone. And again, we have this traditional model with disease on either end, and we have the functional model where we talk about this adaptive thyroid state to the HPA axis. And again, these are the definitions we went over, and we're really going to focus on allostatic load and the thyroid. This is resiliency, and again, overload and toxic stress. And so during restful times, the thyroid is typically under tight control when there's no stress at all, and that's hardly ever. With chronic stress, inflammation, inflammatory syndromes, disease states, the thyroid adapts. And this is referred to thyroid adaptation type 1 and type 2. Why does the thyroid adapt? The thyroid is an energy-consuming organ. So thyroid activation is associated with the use of glutathione, ATP, and oxygen consumption. And if demands exceed the supply, the thyroid is going to downregulate. And what do you see on testing? Low TSH, low T3, low T4, increased reverse T3. I see this all too often where people are being given high doses of thyroid and nothing changes. And then you have thyroid adaptation type 2. And that's where you have plenty of supply with expected increases in demands. And what happens? The thyroid tends to upregulate. And what you'll see, normal or increased TSH just slightly, normal or increased T4, but you will see increased T3 and decreased reverse T3. And so remember that the thyroid is an energy-consuming organ and adapts to the HPA axis. Thyroid adaptation is important as not to overtreat the thyroid. Treating the thyroid will not improve thyroid function without addressing the HPA axis. And so now as we move on to treatments, lifestyle is key and is the hardest to comply with. And remember, it takes about 45 to 60 days to make a change and about 90 days to see the results. Diet's important. Sleep is important. Mindfulness, social support, and then some basic supplements, a good multivitamin, nutrients, vitamin D. And remember, for every 10 you want to increase vitamin D, you need to give 1,000 international units. That's in the literature. So if somebody's vitamin D level is 40 and you want to get them to 60, you give them 2,000 international units. And here are adaptogens, just some examples for high cortisol states, mixed cortisol states, and low cortisol. And remember, get familiar with a few, understand how they work, understand how they interact with other drugs. And once again, I treat these like drugs, start low and go slow. And here are my final thoughts. We live in a stressful world. Most, if not all, patients have some degree of HPA axis dysfunction. HPA axis dysfunction impacts all systems, including sex hormones. Cortisol is the universal stress marker, drives inflammation and all inflammatory diseases and syndromes. Lifestyle interventions are the most effective but hardest treatments to comply with. And really, without lifestyle changes, other treatments will probably not be as successful. And at this point, I thank you for your attention. I hope you all have a happy, healthy, and safe holiday weekend, and we will take any questions.
Dr. Doreen, it looks like we don't have any questions at this time, so we will have to answer those later.
Great. Thanks so much.